in about 20 to 25 minutes. Thank you very much for inviting me to participate in this conference. So we're going to talk about a few case scenarios and walk through approach to infection, at least from a Canadian perspective. And then we will open that up for discussion, as you've said. Okay. So we're going to go through the case reviews. I have a particular vested interest in the Canadian Pediatric Society, as I am the chair of the Fetus and Newborn Committee. And so wherever possible, I like to promote the work that we're doing. We will be going through a statement from the Canadian Pediatric Society related to something that is from the ID committee, however, so I can't take credit for it. And then we'll go through some take-home messages. So in scenario one, and this is meant, obviously we can't do this as an interactive case, but we'll go through it and you can try as we're going through to think about what you would do. And then you'll see a Canadian perspective on things and how we would approach it. So this is a 26-year-old prima gravida mother whose infectious risk workup is negative. Importantly, GBS is negative. She's GDM and PIH. That's a gestational diabetes mellitus, and pregnancy-induced hypertension is well controlled. A baby is born at 37 weeks and 6 days of adequate weight, 3380 grams, wonderful APGAR scores at 9 and 9. And the baby goes to the normal nursery and is breastfeeding. But at 36 hours of age, presents with abnormal movements. The baby begins to experience lip smacking, limbs are cycling, and contrary to what Amr said, our case, they claimed had tonic-clonic movements, although now I have to say I know this is impossible, but this was the case nonetheless. So what would we do? So if you're approaching this, the first thing to do would be to, before you even consider the infectious approach, would be to support the baby. And to that, we go through the NRP, and all of you would be aware of Mr. SOPA. And so once we're attending to the airway of the patient and making sure that they're breathing and that they have good oxygen saturations, we would try such things as applying the mask, repositioning if necessary, suctioning to and opening the airway, applying some pressure, possibly even more pressure if we're giving PPV, and finally considering an alternative airway. If I was approaching a patient like this who is having what I believe to be seizures, I would have to think that common things being common, infection could be a predisposing factor leading to sepsis, then meningitis, pneumonia, although as we'll soon see, meningitis does not necessarily require sepsis. I would worry secondary to the seizures that this could be related to meningitis, as I mentioned, but encephalitis, certainly based on the season, and if you're having viral cases of encephalitis moving through your community, you would want to consider that, and finally neonatal stroke. One of the questions that I'm commonly asked is whether or not we should include a lumbar puncture when we're doing an initial septic workup. I can disclose to you that, and this I will take credit for, Dr. Ann Jeffries was our former head of the committee, but was on the committee when I was chair to produce this document called Management of Term Infants at Increased Risk of Early Onset Bacterial Sepsis. And we discuss a few points in this case that are worth considering. So whether or not you do an LP or not, these are the factors that you need to think about. Meningitis is actually quite uncommon in newly born infants. And I will distinguish that from infants in the sense that a baby in the first 24 hours of life, the likelihood of there being a positive CSF culture is quite low. In this case, this baby's 36 hours of age, so there's ample time for infection to potentially seed the meninges. If a baby is asymptomatic and they are term, there have been 3 large observational studies suggesting that meningitis is exceedingly unlikely, which is why, at least our practice here is we do not do an LP routinely in a baby who's just a few hours of age that's having a routine, not a routine, but an initial septic workup. If you look at babies whose primary issue is respiratory distress, meningitis is similarly extremely uncommon. We do know that newborns with positive blood cultures, though, are more likely to have meningitis, and that's where I think one of the common practices that we see in neonatology of deferring the LP, waiting for the blood cultures, if they come back positive, doing the LP, I think that's where that was born out of. But the problem with that is that anywhere from 8 to 40% of infants, based on the literature, who have meningitis, confirmed meningitis with a bacterial culture from the CSF, have a negative blood culture. So this does raise the question of whether the practice of saying, well, we'll defer the LP, and if it's positive in the bloodstream, we'll do the culture of the CSF, that may not be the right approach. So when we believe that if you suspect there's meningitis, certainly in the presence of seizures, an LP must be performed. If the white count is above 20 to 25 cells, that would definitely be abnormal. And as we've seen with GBS meningitis, you can have a normal white blood cell count in the CSF that falls within that under 25 level, and you still have a culture that's positive. In this case, this baby underwent a CBC blood culture, CRP, and LP, also underwent viral workups based on the time of year, and you may or may not do a urine culture, imaging of the chest to rule out pneumonia, and an EEG. 2 blood cultures came back positive for GBS. There was an elevated CSF protein count, low glucose, high cells, and the CSF culture came back positive for GBS, leading this to be a case of combined GBS meningitis and GBS sepsis. Now we're going to contrast this with case number 2. Case number 2 is a twin pregnancy. GBS in this case is unknown. The pregnancy is otherwise fairly unremarkable. The mother is treated with 2 doses of penicillin prior to delivery after a rupture of membranes for 2 days. So having prolonged rupture, delivery at 28 weeks and 6 days, let's look at what happens to twin A. Twin A is reasonably vigorous at birth, does need PPV, goes on to CPAP and gets caffeine. By the 2nd day of life is on room air, which is actually fairly good. The first blood culture drawn on first day of life is negative at 48 hours, and we stop ampicillin and gentamicin after 2 days. Now that's very common. On the 9th day of life, however, the baby develops increased work of breathing, increased apnea, becomes lethargic, and begins having partially digested residuals, and importantly has hyperglycemia. And as I taught to a group of residents not too long ago, the presence of hyperglycemia to me is always very worrisome, as it often is a sign of stress and often linked to sepsis. So what do? We do a physical exam. We find on the physical exam, the baby's tachycardic with a heart rate of 170, respiratory rate in the 70s. The baby is somewhat mildly hypotensive, and there is indrawing, the saturations are in the 80s. Our differential diagnosis for apnea would be, it could be primary apnea, but unlikely to be just apnea with these other features. Infection, the same infections we talked about before, and of course, one never wants to forget necrotizing enterocolitis. The investigation would be virtually the same as the previous case, including a urine culture. The baby's 9 days of age, so after 3 days of age, we typically will include the urine culture. And the blood work comes back showing an elevated CO2 with a CO2 of 70. The bicarb shows a level of 18, which in a 9-day-old 28-weeker would not be that uncommon given the loss of bicarbonate in the urine. The X-ray, though, shows just low lung volume, no obvious pneumonia, no obvious pneumatosis on abdominal X-ray. We did not have a ultrasound here of the abdomen, but let's just say there's no neck. The CBC shows a hemoglobin of 79, a platelet count of 123, and the CRP is elevated at 20. The CSF in this case comes back clear, normal chemistry, and negative gram stain. So this would be a classic picture of GBS sepsis with CSF cultures and it being negative. One of the important distinctions between this case and the previous case is that about 90% of babies who have meningitis have symptoms, neurological symptoms consistent with meningitis. Now, one could argue that in this case, while there were no seizures, the baby was lethargic, which is a CNS symptom. But it's also true that about 90% of babies who have neurological symptoms have plural, have more than one symptom that is related to the neurological symptoms system. So this, with this baby only having lethargy would really be in keeping with GBS sepsis. So some things to discuss about this case that we need to think about are the difference between early onset sepsis and late onset sepsis. Interestingly, there's no concise, different or definitive definition. So in some places, you'll see people refer to early onset as under 72 hours, some people under 7 days. But suffice to say, we have to draw the line somewhere. Things that you need to think about when you're choosing the antibiotics, of course, are the presence of a central line. We would typically choose vancomycin if we have a central line in place due to coagulase negative staphylococci. As I'm very aware, and I don't know the patterns in Cairo or anywhere else in Egypt for that matter, where you are in the world determines also your antibiotic choice, because some places have higher levels of gram-negative, some places have more fungi that is present or yeast. And you have to also know your local antimicrobial resistance patterns. These are all factors that one needs to think about. Duration of treatment differs, whether it's sepsis versus meningitis. Typically, meningitis will be 21 days. Sepsis, anywhere from 10 to 14, usually until the 10 to 14 days if it's gram-negative, 7 to 10 days if it's gram-positive, from the first negative culture. And we also have to think about confirming that we have a negative. When we're talking about meningitis, though, from the first case, meningitis does leave you with a significant risk of neurological sequelae. A third to a half have significant sequelae. And adverse factors for a very poor outcome would include being comatose at the time of presentation, shock, or a white blood cell count less than 5,000, or an absolute neutrophil less than 1,000, or CSF proteins that are quite high. Scenario 2 is very different. This is a 32-year-old G6P3A2 mom who has a fairly benign history as well, delivers at 29 weeks with APGARs of 7 and 8 and a birth weight of 1.4 kilos. The course in the NICU was very uneventful until the 14th day of life, when the baby begins to develop apnea, periodic breathing, and requires CPAP of 45%. At this point, skin rashes and blisters are noted, and they appear like this. Now, given that I'm speaking to a very educated audience, I'm sure you could figure out what these vesicular lesions would be. But if we do our same approach, we would do a physical exam, come up with a differential diagnosis, look at investigations, and then determine how to manage while we're waiting lab results. The suspected lesions in this case would be herpes. And depending, and I need to be clear on this, depending on, again, where you are in the world and what testing facilities you have and what modalities you have, there will be different ways that you make this diagnosis. But it's important to unroof the lesion, to take swabs. You may do a zinc smear, you may do PCR, but more on that in a minute. When we're thinking about cases like this, and we're thinking about viral CNS infection, which is very high risk with neonatal herpes, we need to distinguish between meningitis or aseptic meningitis, which is an infection of the meninges surrounding the brain, and that's more common when we see meningitis related to bacteria, and encephalitis, which is infection of the brain tissue itself. Many of you will know, because it's a classic question on exams, that herpes is a double-stranded DNA virus. And we know that you can either be infected with oral or genital HSV. What's also interesting, although in Canada, we see about 25% of cases of neonatal herpes related to oral or type 1 HSV, we see type 2 or genital HSV in the other 75%. If you go to other countries, this proportion varies. Additional points, acyclovir has been a real game changer. What's happened is, if prior to the use of acyclovir, historically, disseminated herpes had an 85% mortality, but that's been reduced to 29% with the use of acyclovir. And CNS disease has reduced the mortality from 50% down to 14%. So that is a dramatic effect. When we think about transmission rates, and I find this particularly interesting, if you have lesions at delivery, the risk of the vaginal delivery of transmission to the neonate or a delayed cesarean section with a primary infection is 60%. Primary would be defined as absence of neutralizing antibodies on testing with lesions. Non-primary, and this is something that not everyone realizes, non-primary refers to the fact that you've had herpes of the other type. There's some cross-reactivity. So the example would be, you have a history of cold sores, you have oral herpes, but now you have genital herpes. So you have antibodies against HSV1. So you have a primary outbreak of HSV2, but because you have some cross-reactivity with HSV1 antibodies, there's less risk to the fetus or the newborn of acquiring herpes. So in that case, the transmission rate is under 30%. And with recurrent herpes, it's less than 1 in 50. The importance of doing an LP cannot be stressed enough, as the risk of herpes simplex encephalitis is significant. When we look at the different types, there are 3 different types, as many of you know. Skin eye mucous membrane disease is about 50%. You may actually not have the vesicular lesions, even if you do have skin infection with the virus, and we'll get to that in a minute when it comes to surveillance. Localized CNS disease with or without skin involvement is about 30% of cases, which leaves 20% to be the disseminated type. Acyclovir standard is 60 milligrams per kilogram per day divided Q8H, and the treatments differ depending on whether it's skin eye mucous membrane or CNS. Because of the effect of acyclovir on the kidneys and on the white counts, you need to monitor kidney function and white cell indices while you are on it. And just to make sure everybody's aware, trifluridine is used if you have ocular evidence of herpes. And although it's somewhat controversial, suppressive treatment is provided. it's critical to get that LP and recognize that for the LP, if you are in your practice always saying, we'll just do the LP if the blood culture comes back positive, you're going to miss some cases of meningitis. HSV, think of HSV whenever there's an unusual presentation. And then finally, for line-related sepsis, Staphylococcus aureus is an organism that has to be taken with great respect. And one of the things you can do is try to remove those lines and not leave them in and resist that temptation, which I know we all have, to say just one more day, which sometimes turns into a week. So thank you very much, and I will take any questions.
Thank you very much, Dr. Narvy, for the amazing presentation. Actually, we here in Cairo, we have different pattern of organisms. We have the gram-negative bacteria that is the most common, Klebsiella, for years now, and now turning into the MDR and extended resistant strains. I'm not sure about the experience in herpes. It's not that common here in our units. I work in Cairo University. It's one of the biggest. Same with the GBS. So we have like a different pattern of organisms, but we still have loads of neonatal sepsis, especially late onset ones in our units. I'm not sure if you can have any clues to help with the gram-negative. Do they have the same guidelines? Do we still need to do only lumbar puncture when we see signs, or with gram-negative it's different?
No, I think it is the same. I mean, one of the things that I would encourage everyone to do, and it can be very helpful, is in consultation with your pediatric ID colleagues. They have antibiotograms, which basically look at the resistance patterns in your institution. And I would choose the antibiotics based on, what your local patterns are. And, I worked in China for a month, and when I was there, I was surprised to see that they used, at the time, meropenem and cefotaxime for all of their initial septic workups. And when I asked them, why you're using such big guns, the answer was, because I said, what about GBS? They said, we don't see it.
Yes, we don't.
We don't see GBS, but what we see is E. coli, Klebsiella, Enterobacter in our early neonatal sepsis. I do think that because of the ravages that you can see with gram-negative sepsis, in terms of if you get gram-negative meningitis, the outcomes are expected to be worse. So that's all the more reason to do the LP. And I guess I would go back to what I said before, because I don't want people to leave this talk and start doing LPs on everybody that they see. But at the same time, if you have neurological symptoms, I know that, I assume the practice in Egypt is similar to the practice here. People seem to find reasons not to do the LP.
Yes.
The common reasons are the baby's too unstable, the baby's having apnea, the baby's not intubated. I'll wait, I'll see if the blood culture comes back positive. Like, we hear all the same things. But I think when you're running a risk of missing, let's say 1 in 10 cases or 1 in 5 cases of meningitis because they don't have a positive blood culture, again, I would fall back on saying the children, obviously the ones that are having seizures, are clear cut, need to have an LP. But the ones that perhaps have extreme lethargy, not just a little bit of lethargy, but sometimes the nurses will say this child is really unresponsive to pokes, and yesterday they were very active. That's not a baby that I would wait for the positive blood culture in. I would suggest that baby should have the LP.
Okay. Thank you very much. And I'll see if anyone else has a question to ask. I don't think we have other questions. And thank you very much for the interesting and elegant presentation. I really like the case scenario thing, and I hope to see you soon.
You too. Okay.
Thank you very much indeed. Thank you very much, Maikel. And now, Dr. Dalia. Dr. Dalia. Dr. Dalia. You are muted. Unmute, please. Dr. Dalia. Dr. Dalia.
Oh, is that Alvaro?
That she's available. Dr. Dalia. Okay, Dr. Yasser, Dr. Yasser?
Sure, yes, yeah. Okay, so welcome back, everyone. So it's my pleasure to introduce Dr. Ruben Alvaro. Dr. Ruben Alvaro is the medical director of neonatal sleep laboratory at Health Science Center in Winnipeg, the medical director of neonatology at the San Boniface Hospital, and the associate professor of pediatrics at the University of Manitoba. Dr. Alvaro, neonatal professional activities have compassed education, research, administration, clinical care. His main research focus has been on control of breathing and respiratory care in fetus and newborn. He has also collaborated in many local and international randomized controlled trials, including caffeine for apnea of prematurity and Canadian oxygen trial. He has published over 200 original papers, abstracts, review articles, and book chapters, presented over 100 lectures in national and international conferences and seminars. Dr. Alvaro is going to speak today about approach to respiratory distress in newborn. The floor is yours, Dr. Alvaro.
Thank you, Yasser. Can you hear me?
Yes.
Okay, so thank you, Yasser, for the introduction, and thank you very much for inviting me to participate in this conference. I wish I could be in Egypt right now, which I know is most likely much, much warmer than here in Canada right now. So let me share the screen. Okay. Can you see that well?
Yes, we can.
Okay. Very good. Let me. Okay, so I have two main objectives for today's presentation. I know I only have 20 minutes to present a topic that is could take the whole day to present. So I'm going to try to make it very simple. So the two main objectives for today's presentation is first to